Hi, everyone, and welcome to the latest IGCS Radiation Oncology podcast. I'm Dr. Pearly Khaw. I'm a radiation oncologist in Melbourne, Australia, and the current IGCS Radiation Oncology Education Work Group Chair. Today, I have the pleasure of interviewing Dr. Anne Sophie von den Heerik. She is a radiation oncology resident at the Leiden University, where she is currently in training and also aiming to complete her PhD. She is the lead author for PORTEC 4A, which has recently reported their findings at ESTRO 25 in Vienna. Welcome, Anne Sophia.
Thank you very much. Great to be here. Thank you for the invitation.
Wonderful to actually finally meet you. Now,
Likewise.
we have been waiting for some time for the results of PORTEC 4A. For those of us who weren't lucky enough to be at this late-breaking presentation, would you like to take us through some of the main highlights from the trial?
Yes, of course. So first of all, the PORTEC 4A trial is an international multi-center trial, which was started in the Netherlands, and it had its inclusion period between 2016 and 2021. And what makes the PORTEC 4A trial very special is that it's the first trial to prospectively investigate a molecular integrated risk profile within patients with high intermediate risk disease and in endometrial cancer patients, sorry. And what we saw is that based on a 5-year cumulative incidence, that the recurrence rate of vaginal recurrences was not inferior to standard vaginal brachytherapy. Because as you might know, that patients with high intermediate risk disease based on the PORTEC 2 trial were over the past decade treated by vaginal brachytherapy. And what we tried to what we did in the PORTEC 4A trial was that we used a molecular integrated risk profile to more select patients for an individualized treatment. So for some patients who were at a low risk for recurrence, adjuvant treatment, vaginal brachytherapy was admitted. Whereas for patients who had a higher disease risk recurrence, those were scheduled for pelvic radiotherapy. And what we saw that there were no differences, first of all, in our primary endpoint, which was vaginal recurrence, but also not in other tumor controls. So for instance, pelvic, but also local regional, meaning vaginal as well as pelvic. And we didn't see any differences in recurrence-free and overall survival. But what was most important was that by using this approach, that almost half of the high intermediate risk endometrial cancer patients can be spared the burden of adjuvant treatment, which in this case would be vaginal brachytherapy.
So if we go back a couple of steps and look at actually how PORTEC 4A came into being. High intermediate risk features for endometrial cancer. Do you want to take us through where we started from and how we got to the point where the investigators moved to using molecular profiling in trying to help us sort this out?
Yes, of course. So if we really go back, we can first start, of course, with the PORTEC 1 trial. In this trial, patients with mostly intermediate and low intermediate risk disease were included, and they were randomized between pelvic radiotherapy as well as no adjuvant treatment after surgery. And what we saw was that there were no differences in overall survival, but that patients were more adequately treated by receiving pelvic radiotherapy. But what you can also imagine that giving pelvic radiotherapy to all patients can be quite burdensome, especially regarding the toxicity related to it. And interestingly, they saw, based on the recurrence pattern, that most recurrences occurred in the vaginal fold. And this sparked the decision to perform the PORTEC-2 trial, which randomized patients of a higher risk disease between external beam radiation therapy and brachytherapy. And they saw that the vaginal control in both arms, which was their primary endpoint, were equal to each other. Well, vaginal brachytherapy is far less burdensome in regard to toxicity than pelvic radiotherapy. And that also led to having vaginal brachytherapy as the, well, adjuvant treatment of choice for these patients. But still, when we looked at that patient subgroup, there were some few discussions between radiation oncologists. And one of those were if all recurrences are within the vaginal fold, and also looking back at the salvage results of the PORTEC-1 trial, they saw that it can be very well salvaged. Most recurrences located in the vaginal fold can be salvaged by, for instance, radiotherapy or surgery. So this sparked a discussion whether treating all patients with vaginal brachytherapy can also be considered overtreatment. And on the other side of the spectrum, we saw on long-term analysis of the PORTEC-2 trial that there were a small subgroup of patients who were at a higher risk for both pelvic as well as distant recurrences. So that led that there was still an, you can say an unmet need for further refinement within this subgroup. And in the meantime, we had, of course, the publication by the Cancer Genome Atlas work group in 2013 in this subgroup, well, not subgroup, but in endometrial cancer patients. And what we saw was there are 4 molecular subgroups: POI, mismatch repair deficient, P53, and tumors lacking any of these 3 molecular classifications are called no specific molecular profile. So the NSMP subgroup, which is the last one. And using these molecular markers as well as other, let's say, historic clinical pathological risk factors, within our study group of the Leiden University Medical Center, we were able to define a molecular integrated risk profile, which combined, apart from the molecular classification, also substantial LVSI and overexpression of L1CAM. And what we saw, if using this approach, we can further refine within the high intermediate risk endometrial cancer subgroup. And this refinement is also on the basis of the PORTEC-4 trial, because patients with a favorable risk profile are also the favorable patients in the PORTEC-4 trial, so in who adjuvant treatment was admitted. Whereas for patients with an unfavorable risk profile, who also, based on the molecular analysis, seem to perform poorly regarding disease control, those patients with an unfavorable profile in the PORTEC-4 trial are receiving pelvic radiotherapy, whereas patients with an intermediate profile are receiving the standard of care, vaginal brachytherapy. So that's in also what we see, well, what we do in the PORTEC-4 trial, the 3 molecular risk profiles within high intermediate risk endometrial cancer patients.
If we think a little more about that, though, the drive now is towards molecular profiling, but not every country in the world has ready access to molecular profiling. You hinted in your presentation a bit about surrogate markers. What alternatives are out there for those of us who can't get or have no access to next generation sequencing to help make these decisions?
Yeah, that's also something that we have discussed within our team as well. And what we also know, of course, you have your surrogate markers for the mismatch repair deficiency, for P53. And most of us can also perform for the estrogen and progesterone markers, but of course, POI and beta-catenin and L1CAM can be difficult and are not readily available, as you already said. What we also hoped already in the few years before this publication is that NGS gets more available across the world. But in the meantime, we see that also a few people have tried to look in other alternatives for POE sequencing. There are a few kits available to perform qPCR, which is a different way of looking at certain mutations. We from the Leiden University have also developed a qPCR method, and I know that there are also other manufacturers which are currently working on it to make it more readily available for more pathology labs, because of course NGS isn't always available, whereas a qPCR is more available. So hopefully we will see that more kits like that will be available and are manufactured. Luckily, one of the things which is also included in the molecular integrated risk profile is substantial LVSI, which you wouldn't need a surrogate marker for, because that's based on your H&E slide. But the last thing you said, of course, is overexpression of L1-Chem. Well, not the last thing, one of the last things. For L1-Chem, luckily it's immunohistochemistry. So it is more available than next generation sequencing, but of course you would need a dedicated pathologist or pathology lab who would like to implement it as well. And lastly, we have beta-catenin, which is a range of mutations. So a qPCR will be very difficult for it. So the golden standard is still NGS. You can perform Sanger sequencing for it, but preferably, of course, next generation sequencing. But what we really hope to see in the PORTEC is not only the results of a primary endpoint, meaning that there is no difference, but that you are treating are over-treating less patients. We are also currently in the process of performing a cost utility analysis of the results of the PORTEC trial, and we have taken a time horizon of 3 years. So from randomization up and 3 years after randomization, and we are taking in account in this analysis not only the costs for the diagnostics, but also the costs for adjuvant treatment, and also the cost for the treatment for recurrences. And what we of course hope to see is that although the costs in the diagnostics are higher because you would still need your NGS, is that it will be offset by the reduction of performance of administration of vaginal brachytherapy for half of the patients, which will ultimately lead, of course, to some kind of balance. Because I think most of us, or most across the world, will say that performing the molecular classification is more costly than not performing it. But what we hope to see in the PORTEC trial is that it is at least equal to each other, or potentially in some parts of the disease management even cheaper. Because what I already said, higher cost for this diagnostics, but lower cost for the adjuvant treatment.
Are you also going to look at things like return, for the patient to be able to go back to work, less financial distress, that don't have the issues of having to have treatment, but then balancing that with the patients who have recurrence, what sort of burden that might be in a health economics forum? Are they sort of features that you're going to look into over this period? Sorry, I should clarify.
No, I think I already got what you were asking. We are not implementing it in our cost utility analysis, and the main reason for it is that the median age of patients in the PORTEC trial was around 69, 17 years old, so they are not really in a working environment, to say so. But we are performing analyses in health-related quality of life. So what we saw is that there is in the first analysis we didn't see that many differences in toxicity, which was also some kind of expected because mostly it were low-grade toxicities. And what we really hope by performing our analysis relating to health-related quality of life, that we can look into small differences regarding the quality of life of the patient. So, for instance, not only symptoms, for instance, gastrointestinal or genitourinary, but also emotional distress, role functioning, and physical functioning. So we will look into that for the health-related quality of life analysis, but we won't take that into account for the cost utility. We will only look into the endometrial cancer-related healthcare cost, and we will perform the analysis based on a healthcare perspective, because we chose also the healthcare perspective because we want, hopefully we can show with the cost utility analysis that it is cost effective to use the molecular integrated risk profile instead of using standard brachytherapy. And by doing so, it will hopefully give a lot of international societies, but also local societies, the ability to step forward to their governments and say, we have now information available, we have data available showing that we should use a more individualized treatment approach for patients with high intermediate risk endometrial cancer. And hopefully that will spark the implementation of, or the possibility to have cheaper methods for, not cheaper methods, but better accessibility for next generation sequencing around the world or in more places than just a few localized hospitals.
So one of the things I guess I'm most curious to find out is, why did the investigators choose vaginal recurrence as the primary endpoint, leaving relapse-free survival, overall survival as a secondary endpoint?
Yeah, so what we know is, if we look back at the previous trials, which are on the basis of the PORTEC trial, is that the PORTEC-1 trial already showed that the majority of the the majority of recurrences were within the vaginal fold, which led to the initiation of the PORTEC-2 trial, which also had as primary endpoint the vaginal recurrence rate. And they saw that if you use pelvic radiotherapy or vaginal brachytherapy, that the vaginal control was the same without any differences in recurrence-free or overall survival. So since this is some kind of a follow-up trial of the PORTEC-2 trial, because it's mostly high intermediate risk patients, we chose the same endpoint because we also didn't expect that when using a molecular integrated risk profile that it would impact overall or recurrence-free survival. But giving the optimal salvage methods in case of a vaginal recurrence led to using the same endpoint for the PORTEC trial, which is vaginal recurrence.
And yet your results were really very good, because of the total number of patients, you report only 23 vaginal recurrences, and of those 23, only 8 were isolated, and 4 in the distal vagina, showing that we could salvage those fairly effectively. Did that have an impact, do you think, in the overall results, that this number is actually very, very small?
Yes, it does. And it's also important to mention that of those 23 vaginal recurrences, that only 18 of those were as first event, meaning that also some recurrences occurred after another recurrence. For instance, distant. We had a few patients who had first a distant recurrence and then also had the vaginal recurrence. So that's still 18 patients who had as a vaginal recurrence as their first recurrence, of the total of 564 patients. So that's a very little number, of which we are very happy, of course, because that means that using this primary endpoint, that most patients are still very adequately treated.
My follow-up question to you, Anne Sophie, though, is how did the trial define distant Mets? So local regional recurrence being pelvic, vaginal.
Mm-hmm.
When you define distant Mets, did that include, say, a para-aortic nodal recurrence? Or were you referring lung, superclav, that as your distant Met?
Yeah. So we used, but I have to check this, up until the lower para-aortic nodals as pelvic and above as distant, meaning that we used abdominal as well as, for instance, like you said, lung or periclavicular as distant. We combined those, so we didn't look specifically in a difference between abdominal versus distant, meaning lung.
I guess because I'm curious that if it was a distant met failure and it was abdominal nodal failure, whether that was salvageable as well. Just as a curious question for you there.
Yeah, so I know that because I've also been working on the cost-utility analysis, that there were also a few isolated abdominal recurrences who were, for instance, treated by surgery or radiotherapy or in combination of chemoradiation. And a few of those, but I don't know number at the top of my head, were salvaged or were at the time of my analysis, which I said is 3 years, were still alive without evidence of disease. But it's of course very interesting because unfortunately the numbers are small, so that means that we are not really able to perform any multivariate analysis to specifically look into for instance, let's say overexpression of L1-chem or substantial LVSI. We have to really rely on previous publications which showed the impact of it. But it's of course very interesting to look at the patients who recurred and how they were treated and if they were salvaged. So I can imagine that it's food for thought and food also for an additional publication to look in how the patients who were diagnosed with recurrent disease were treated afterwards.
If we look then, because you looked more in, you reported on your molecular profile cohort, separating your favorable, which were your poly patients, versus your unfavorable, which were your P53 abnormal. Can you step us through the results for the poly group, where you've reported that it has shown that it is non-inferior for us to use observation in place of volt brachytherapy? When I look at the absolute numbers that you showed, I'm probably not getting that message. So how would you explain that?
Yeah, I think it's first of all important to highlight that within the favorable patients are not only the POI patients, there are also the no specific molecular profile subgroup patients who do not have a BETKT mutation. And what we saw is that if we look in these subgroup specifically, that of the 169 patients within the molecular profile arm, only 6 of them had a vaginal recurrence. And if we look in the standard arm, because we also determined the molecular profile in the standard arm, but there wasn't any treatment implications depending on it, but we still looked because otherwise we can't make the difference between the two arms. But within 109 patients who were in the favorable profile subgroup who received brachytherapy, only 1 had a vaginal recurrence. So the numbers are very small, and I know that it comes to an cumulative incidence between the two arms of 4.1 versus 0.9. But when we look at the statistical meaning of it, we see that there is no statistical difference. And what we also saw is that when we performed our sample size calculation for this subgroup analysis, that it's all within the pre-specified boundaries, which we use as the PORTEC 2, because we use the PORTEC 2 trial results to determine our sample size for the PORTEC 4 trial. So it's perfectly within those boundaries. And although there's a numerical difference, there's no statistical difference. I think that's one of the key points which you should remember, and especially that of those 169 patients, those all didn't receive vaginal brachytherapy. And most of them when they had the vaginal recurrence were still salvaged and are currently still without evidence of disease. So that still means that 160, sorry, yeah.
I was going to say that's a very good take-home message. They've been salvaged and they're still disease-free. I guess that now leads us to looking at that unfavourable group, which is your P53 abnormals. And I think one of the key messages here, which you also bring up in your conclusion, is that this group receiving pelvic RT fared a lot better than the group that got vault brachytherapy. Do you want to take us through a little bit about why, what the results showed, how confident we can be in actually maybe in the future recommending that?
Yeah, so within the unfavorable subgroup, there were patients with P53 abnormal tumors, but also substantial LVSI or overexpression of L1-CAM. And we know from previous studies that those three markers are associated with a higher disease recurrence risk. And we saw, and it's most interestingly, I think, if we look into the local regional recurrences within this subgroup, because that's both vaginal as well as a pelvic recurrence. And we saw for patients who received pelvic radiotherapy that there was a cumulative incidence for local regional recurrence of 8.4% versus 30.5% for those who received brachytherapy. So that's a big difference. Unfortunately, the hazard risk ratio is nearly statistical significant, but it's important to say that only a small subset of patients had these high risk features within the high intermediate risk endometrial cancer subgroup. It's what we also know, the majority of our high intermediate risk patients are mostly NSMP tumors with only very rarely a P53 abnormal, and in about 8% overexpression of L1-CAM or substantial LVSI. But still, if we look at our results, it's a very, very interesting difference between the two arms. And it really shows that by giving those patients only brachytherapy, we are potentially under-treating them. So this really gives way for a more intensified treatment strategy in these patients. And that can be, for instance, pelvic radiotherapy.
And highly selected.
Yeah.
So we're targeting the right population this way. So as we draw to a close here, what would be your take-home messages from PORTEC 4A for our audience?
So what we showed in the PORTEC 4A is that it's safe to use a molecular integrated risk profile, which helps to further individualize adjuvant treatment for patients with high intermediate risk disease. And we are currently working on analysis for toxicity, health-related quality of life, and the cost-utility analysis. So hopefully, if we have all these analyses ready and to go and for publication, we can help all endometrial cancer patients across the world to the best treatment they should get and should receive.
Thank you, Anne Sophie, for joining us today on this podcast. We really look forward to your final publication. Well, probably your first publication. I can see that there's likely to be a few publications that will come from this particular study. So congratulations.
Thank you so much for having me today.